know that everyone's had some lunch and had some cake now and hopefully recaffeinated a little bit, but if not, we're going to fire things up, get the blood pressure up a little bit with the debates now. So this is one of the most things I'm really looking forward to about today is hearing some hot topics in our field, but also hearing it from some outstanding lecturers. So I'll start off by introducing the first debate, which will be on left atrial appendage closure for atrial fibrillation management. Is it time for devices, or is it the gold standard remains medical management? So starting off the debate will be the position of device with Dr. Sachin Goel. Dr. Goel is an interventional cardiologist at Methodist DeBakey Heart Center. He trained in residency and fellowship at the Cleveland Clinic and now serves as the medical director for the structural heart interventions at our institution. Here he performs many procedures to make sure the brain gets the blood it needs from the heart. That's the job of the heart, including all the transcatheter valve procedures, atrial septal defect, PFO closures, and transcatheter left atrial appendage closure, which is the topic of this forum. So we're very, very fortunate to have him to share his expertise in appendage closure. Dr. Goel.
Thank you, Dr. Volpe and the organizers for inviting me to speak. And over the next 20 minutes, I'm going to try to make a case for left atrial appendage closure. I know I'm surrounded by neurologists, and so I've got my guardrails on. So here are my disclosures. So, I thought that I would sort of organize this debate into, a brief introduction as to why we're having this debate. We'll talk about the issues with DOACs, or direct oral anticoagulants. We'll talk a little bit about the published left atrial appendage closure data, and then talk about the comparison between appendage closure and DOAC, a brief introduction to the cost effectiveness, and then last we'll end with some newer data, some newer and safer left atrial appendage closure devices that are on the block. So you all know atrial fibrillation is a major health challenge with increasing prevalence. There are estimated to be over 12 million individuals with atrial fibrillation by 2030 in the United States. AFib increases the risk of stroke fivefold. 25% of ischemic strokes are associated with atrial fibrillation, and DOACs have become really the mainstay for stroke prevention due to lower risk of bleeding and intracranial hemorrhage compared to warfarin. And this is the most dreaded thing, the left atrial appendage thrombus that we're trying to prevent here with oral anticoagulation or left atrial appendage closure. So what are the issues with DOAC? DOACs are better than warfarin. However, they're still associated with the bleeding risk. And the bleeding risk varies depending on the study you look at, anywhere from 2% to 3.6% from the RCTs, including intracranial hemorrhage. Issues with compliance, underusing and underdosing of the DOACs, recurrent stroke or DOAC failure is a problem. The cost, of course, is an issue in some patients. And then there are GI and some other side effects. In this study, looking at patients who have history of atrial fibrillation and are on oral anticoagulation, the prevalence of them taking a DOAC was found to be increasing over time, partly related to increasing use of DOACs in patients with atrial fibrillation compared to warfarin. But nevertheless, increasing numbers of patients with ischemic stroke and AFib are already taking a DOAC. So DOACs, as you know, are associated with bleeding, nuisance bleeding, GI bleeding or GU bleeding. It's a big issue we see in the hospitals. These kinds of falls or injury-related hematomas and ecchymosis. Intracranial hemorrhage, one of the most feared complications, still occurs. And then, these kinds of microbleeds, which, you neurologists are probably more familiar with. But we're starting to recognize this, as an increasing problem with anticoagulation. We, as a cardiologist, we never used to look at brain MRIs and brain CTs, but, now we are. And I'm sure as neurologists, you're looking at more echoes, or you will, as you are CT and brain MRIs in the future. So bleeding is a big issue. We all know that. What about adherence? Just one slide on this. This is a retrospective analysis of over 60,000 patients using a large commercial US insurance database, and they found adherence as defined by more than 80% compliance or adherence to DOAC was found in only 47.5 patients over a follow-up period of 1 year. So still less than 50%. Warfarin is even lower, but even with a DOAC, the adherence rates are less than 50% over a large cohort of patients. A couple of slides on ischemic stroke despite a DOAC. These are data from neurology literature. This is a pooled analysis of 7 prospective cohort studies of over 5,000 patients with AFib and recent ischemic stroke. Median CHA2DS2-VASc of 5. Prior oral anticoagulation was associated with increased risk of recurrent ischemic stroke. Change in oral anticoagulation from one DOAC to the other or from a DOAC to warfarin did not seem to reduce the risk of ischemic stroke. The annual risk of ischemic stroke in patients who had AFib-related ischemic stroke while taking an oral anticoagulant was 8.9 per 100 patient years. And they concluded that we need better ischemic stroke preventive strategies in these patients. A similar study, this is the Reno Extend study, which you probably are more familiar than I am. This was a prospective multicenter study, over 1,000 patients. Again, similar story, recurrent ischemic stroke and systemic embolism rates of 9.7 per 100 patient years. Same conclusion, further research needed to improve secondary prevention in patients with AFib and stroke despite an oral anticoagulant. So this is a growing problem. So shifting gears, we'll spend a few minutes talking about the published data on left atrial appendage closure. This is the first study, the PROTECT AF, which enrolled patients between 2005 and 2008. The two trials that I'm going to talk about, the PROTECT AF and the PREVAIL, these are the early data. These are comparing the older generation Watchman device with warfarin. These are not comparisons with DOAC, but these are relevant and I think worth spending a minute or two talking about. So the primary efficacy outcome was stroke, systemic embolism, or cardiovascular death. And the primary safety endpoint was composite of major bleeding outcomes, major bleeding events, and procedure-related complications. And as you can see, this is a 4-year follow-up from the PROTECT Tower that was subsequently published in the JAMA. And the device seems to be doing better from a primary efficacy standpoint as well as the primary safety standpoint. There was no difference. When you look at the outcomes stratified by stroke, cardiovascular mortality, and all-cause mortality, these were interesting findings. The incidence of ischemic stroke over 4-year follow-up was no different between the device, which was the older generation Watchman device, and the warfarin. However, there was a signal towards a lower mortality, all-cause mortality, and cardiovascular mortality in patients who received left atrial appendage closure with the Watchman device compared to warfarin over the 4-year follow-up. Important to note that this was the first trial. This was early experience with the Watchman device, and the risk of serious pericardial effusion requiring drainage or surgery was substantial, about 4.8%. And as a result, the FDA mandated that another trial be performed before approval of this device in the United States, understandably so. So in any case, the conclusion from the PROTECT AF after 3.8 years of follow-up was that in patients with non-valvular AFib at increased risk of stroke, percutaneous LAA closure met criteria for both non-inferiority and superiority compared with warfarin therapy for preventing the outcome of stroke, systemic embolism, and cardiovascular death, as well as superiority for cardiovascular mortality and all-cause mortality. And then subsequently, the PREVAIL RCT was performed as required by the FDA. This was, again, similar trial design, Watchman implant versus warfarin in patients with non-valvular AFib with CHA2DS2-VASc, CHA2DS2 score of more than or equal to 2. And it was found that the LAA occlusion was non-inferior to warfarin for ischemic stroke or systemic embolization. Non-inferiority was not achieved for overall efficacy. This was there are multiple reasons for this, and in the interest of time, we probably won't go into all this, or we can discuss this later. But the point was that procedural safety and success was improved compared to the PROTECT AF, and this trial provided additional evidence that LAA closure was safe and effective alternative to Coumadin in patients with non-valvular AFib. And then finally, the 5-year outcomes data from PROTECT and PREVAIL was published in the form of a patient-level meta-analysis in the Journal of the American College of Cardiology in 2017. Here are the outcomes. They found that LAA with Watchman provides stroke prevention in non-valvular AFib to a similar degree as oral anticoagulation with warfarin. However, compared to warfarin, it is associated with reduction in hemorrhagic stroke, disabling or fatal stroke, major bleeding, all-cause mortality, and cardiovascular mortality. So these are the conclusions from this 5-year outcomes patient-level meta-analysis from these 2 randomized studies. Again, remember this is Watchman, the old generation Watchman device compared with warfarin. At the time, the guidelines gave Watchman or left atrial appendage closure a 2B recommendation. However, the most recent ACC/AHA HRS guidelines came out in 2024, just recently, and they have upgraded the indication to a 2A indication. And you can see in patients with atrial fibrillation with moderate to high risk of stroke, defined by a CHA2DS2-VASc score of 2 or more, and a contraindication to long-term oral anticoagulation due to non-reversible cause, percutaneous LAO is reasonable. On the other hand, in patients in which the anticoagulation is not contraindicated, but they are at high risk for bleeding, LAO may be a reasonable alternative to oral anticoagulation based on patient preference, and of course with careful consideration of procedural risk and oral anticoagulation. That's still a 2B indication. And what are these situations? So this is clearly from the guidelines. The patients, I would focus on the left side here. Long-term anticoagulation is contraindicated in patients with severe bleeding due to a non-reversible cause, including the GI, pulmonary, or genitourinary systems, spontaneous intracranial or intraspinal bleeding due to non-reversible cause, or serious bleeding due to recurrent falls when the cause of falls is not felt to be treatable. So these are clearly from the guidelines. This is a class 2A indication in these patient groups. You all know the CHA2DS2-VASc score. We don't need to go into all this. The guidelines do acknowledge that there are additional risk factors that increase the risk of stroke, which are not included in the CHA2DS2-VASc score. And I would focus on this table on the right side, which includes patients with high AFib burden, long duration, persistent or permanent AFib compared to paroxysmal, obese patients, hypertrophic cardiomyopathy, poorly controlled hypertension, those with renal dysfunction, and huge atria. These are other things that we take into account, of course, but they're not part of the CHA2DS2-VASc. So these are the published Watchman data. What about appendage closure versus DOACs? So we'll spend next few minutes talking about this. So there's a large Danish registry which published their data looking at left atrial appendage closure versus DOACs. This was a propensity matched study. This was predominantly done with the Amulet study. The Amulet is the Amulet device. The Amulet device is the other device which is now approved in the United States other than Watchman. It's a slightly different design. We'll talk about this later. But suffice to say, in this study, this was the Amulet device which was used for appendage closure, and patients were compared with all of the patients with AFib who were on a direct oral anticoagulant or a DOAC. And these patients were propensity matched and compared between LAAC with the Amulet device versus a DOAC. And you can see during follow-up, so the patients were mean age of 35, 30%, 75, 30% had prior stroke, 75% had prior bleeding event. Median follow-up was 2 years. CHA2DS2-VASc score was about 4.2. Hasbled was about 3.3. At 2 years, 58% patients had discontinued DOACs for various reasons. Only 24% patients continued for the entire duration of 2 years. And you can see on the right side in the Kaplan-Meier curve, the cumulative incidence of primary outcome, which is ischemic stroke, major bleeding, or mortality, was significantly in favor of the left atrial appendage closure in the red compared to the DOAC in blue. Again, this is not randomized, but this is a pretty good study, propensity matched, all comers, large group of patients in Denmark. And you can see the hazard ratios on the bottom there. The ischemic stroke hazard ratio is no different, 1.1 with the 95% confidence interval crossing unity. But you can see all the other outcomes, major bleeding, all-cause mortality, cardiovascular mortality, in favor of left atrial appendage closure. Prague 17 was a randomized trial. This was a trial performed in Europe. This looked at left atrial appendage closure with the Watchman device compared with a DOAC. 10 centers in the Czech Republic, 2015 to 2019, mean age of 73, mean CHA2DS2-VASc of 4.7, history of cardioembolism in 35%, significant bleeding in almost 50% patients. And you can see the primary endpoint of stroke, TIA, systemic embolism, cardiovascular death, bleeding or complications, no different. So this was non-inferior. Left atrial appendage closure was non-inferior. This was a 400-patient randomized trial, non-inferior in terms of primary endpoint. And on the right side, you'll see the hazard ratios and the p-values. The benefit was in terms of non-procedural major bleeding, which was obviously in favor of the appendage closure, a 47% relative risk reduction in the incidence of major non-procedural bleeding. The 4-year follow-up from the Prague trial was recently published in 2022 in the JACC. And again, similar message. The primary endpoint, no different, still non-inferior. Stroke or TIA, importantly, no different over 4 years. So it was very reassuring to see similar rates of ischemic stroke between left atrial appendage closure and DOACs without a signal of late ischemic events. We'll talk a little bit about this. There's been some concerns about device-related thrombus and peri-device leaks and their association with ischemic events. So it was very reassuring to see this from a randomized trial, that even during 4-year follow-up, there was no difference compared to a DOAC. Again, the benefit with the left atrial appendage closure was in terms of non-procedure, clinically relevant bleeding. So the message was still the same. This is US data, non-randomized. This is recently published in Circulation just last year. 4,000 women and over 5,000 men who underwent left atrial appendage closure were propensity matched 1-to-1 to those receiving an oral anticoagulant between 2015 and 2019. And they found a more than 50% reduction in mortality in the patients undergoing left atrial appendage closure in both men and women. 35% risk reduction in stroke and systemic embolism in those treated with left atrial appendage closure, again in both men and women. And the bleeding risk was interesting. Initially, there was a higher risk of bleeding in those undergoing left atrial appendage closure. However, after the first 12 months, the bleeding curves are flipped. And you can see over the long term, the benefit is in favor of the left atrial appendage. How do you explain the initial increase in bleeding risk? Well, up until recently, the FDA labeling for the Watchman device was initial use of an oral anticoagulant in addition to aspirin for the first 6 weeks. Only recently, the FDA labeling has changed to ADAPT. So it is presumable that in the initial post-operative period, these high-risk patients who were otherwise not great candidates for oral anticoagulation were at increased risk of bleeding and indeed had higher incidence of bleeding with the oral anticoagulant. But in any case, these are non-randomized data, but again, the signals, the message from all of these studies is the same, that it is associated with reduced risk of bleeding, and there are signals towards improved mortality. We interventional cardiologists, do a lot of things inspired by surgeons. So, I threw a couple of slides here. This is an important study that you all should be, you are aware of, the LAOS-3, the LAOS-3 study, which is the left atrial appendage occlusion during cardiac surgery to prevent stroke. This was a multi-center randomized study. Patients with atrial fibrillation, CHA2DS2-VASc of 2 or more, undergoing cardiac surgery for whatever reason, CABG, valve replacement. They randomized patients to left atrial occlusion surgically. This is not transcatheter, this is surgically, versus no occlusion, which included usual care, including an oral anticoagulant. About 2,300 patients in each arm. Primary outcome was ischemic stroke or systemic embolism during follow-up. What did they find? During follow-up, the cumulative incidence of the primary outcome was statistically significant in favor of the patients that underwent closure of their left atrial appendage, as opposed to where the surgeon left it alone. And on the right side, you can see the plots here. No matter how you look at the data, age, gender, CHA2DS2-VASc, surgery, hypertension, no matter how you look at it, all the benefit seems to be in the signaling towards the occlusion of the appendage in these patients. These are some of the ongoing randomized controlled trials comparing left atrial appendage closure with various devices. We have the Watchman device and the Amulet device versus a DOAC. The Champion AFib has already completed enrollment. So over the next few years, we'll start seeing the results of some of these randomized trials, looking at left atrial appendage closure and DOACs. So what does this look like in the contemporary era? So as I mentioned, PROTECT and PREVAIL were done in almost over a decade now, 15 years ago. PROTECT enrolled between 2005 and 2008, so that was a long time ago. A lot of things have changed. So these are some of the contemporary data looking at the left atrial appendage closure in the United States. The NCDR mandates the registry, the LAA registry by the FDA. So over 38,000 patients undergoing left atrial appendage closure were analyzed in this study. Mean age of 76, CHA2DS2-VASc of 4.6. As you can see, the number of atrial appendage closure procedures are increasing in the United States. And I would focus on the adverse outcomes on the left side here. The incidence of death, 0.19%, stroke or TIA, 0.17%, pericardial effusion, 1.3%, 1.4%. Recall in the PROTECT AFib, the incidence of pericardial effusions was upwards of 4%, 5%. So the FDA mandated the other study. But over time, the incidence of these adverse outcomes is coming down. This is undoubtedly related to improvement in technology, improved operator experience, improved imaging, a combination of things. Concomitantly, the implant success rates has also gone up from 90% in the PROTECT AFib to 98.3% in this NCDR LAO registry. Last few slides on some of the newer devices. So the Watchman device, the original Watchman device, looks and was very different compared to what we have now, which is the Watchman Flex device. The Watchman, so all the PROTECT and the Prevail, all these studies were done with the old Watchman device or the Watchman 2.5 device. Now we have a better device, which is the Watchman Flex device. It has a larger size range, so we are able to close a wider range of appendages. It is a shorter device with a dual row of anchors. The shorter row of the shorter device is very helpful because, as you see in the previous version, you have these long arms or legs of the device, and you can imagine that if you implant this deep in the appendage, there is a higher risk of perforation. Whereas this one is much shorter, so we don't implant this very deep. We implant this at the ostium. The risk of perforation and pericardial effusion seems to be lower, as you'll see in the subsequent data. The distal tines are folded back. There are a greater number of struts, 18 struts versus 10 struts in the older Watchman device. This allows the device to conform better to the appendage, and there's reduced metal exposure, which presumably will help reduce the risk of device thrombosis. The Pinnacle Flex study, I'll go over this quickly in the interest of time. The device complications are much lower now with the Flex device, 0.5%, and you can see all these other device complications in the previous studies. This is the data from the NCDR. Again, same signal. The device-related complications are decreasing. The in-hospital adverse events, pericardial effusion, 1.2% versus 0.4% with the Watchman Flex. Device embolization, 0.02%. Major bleeding, 1%. Major vascular complication, 1%. So the signals are in the right direction. The risk of complications is going down. We cardiologists think we are perfect. We probably are, but maybe we are not. There are problems with our procedures and devices. Two things that I would like to highlight, which you already know probably: the device-related thrombus. This has been a problem with the left atrial appendage closure, and this is associated with increased risk of stroke. And this has been published. And the DAPT versus oral anticoagulation, this has been studied in most of the literature so far. Oral anticoagulation was required for 6 weeks after appendage closure, but in the DAPT Flex study, we found that there was no difference if you use DAPT after appendage closure as opposed to an oral anticoagulant, and less risk of bleeding. Peri-device leak is the other one, which is still a problem, but perhaps the incidence of this is also going down with the Watchman Flex and with the Amulet devices, which has a disc and a lobe design compared to the Watchman. Here's the Amulet IDE. The 3-year outcomes were recently published comparing the Amulet occluder to the Watchman device, and the device was found to be non-inferior to the Watchman, but the main signal of benefit was in the incidence of peri-device leak, and that has something to do with the device design, which has a disc that provides complete occlusion of the appendage. So we'll learn more about this. Cost effectiveness. I'll go through this quickly. This was a Markov model analysis over 20 years, and in this cost effectiveness analysis, you can see in the bottom right quadrant, the appendage closure was found to be more effective and less expensive in the long run over a 20-year simulation based upon this Markov modeling compared to oral anticoagulation. We have a whole host of new devices that are on the block that are being studied. We talked about the Watchman, a little bit about the Amulet. There's this laminar device, which is a very interesting device. This is like a bread bag where you go inside the appendage with a little ball and you twist the appendage and you close it, and you don't leave anything behind. So this is very interesting, exciting, new technology. Some preclinical data looks very promising. The idea is, nothing sticks out of the appendage. There's going to be no leak, presumably lower risk of device-related thrombus. So we're going to be part of this study. So in conclusion, I think, left atrial appendage closure versus DOAC, there's reduced risk of major bleeding, non-procedure related, clinically relevant bleeding, intracranial bleeding, reduced mortality. It seems to be cost effective. There doesn't seem to be any issues with compliance with this as opposed to oral anticoagulants. Procedural risks are significantly lower now compared to the older randomized controlled trials, and devices are getting better and safer. So I think it is time to take the leap. Thank you very much.